Hi everybody. My name is Minjun. As thank you for the introduction. I'm a student from St. Louis University. I do have one more week left, and today I just wanted to do a quick case report and kind of a literature review, I guess, on intracranial aneurysms. So for our case presentation, we have a 46-year-old female that comes with a severe headache. So we kind of do a basic workup and we find out that her headaches are kind of diffuse, severe headaches that started suddenly in the morning, and her past medical history is not too significant. She does have a family history of cerebral aneurysm rupture from her father, where he did pass away, and her medications are albuterol PRN. She does not have any surgical history, and she does not have any histories of migraines or cluster headaches or anything like that, or just tension headaches in general. On physical exam was mostly benign, except for the fact that she was very uncomfortable anal times two and eyes closed. We didn't see any specific neurological deficits except for meningismus, and her cardiopulmonary and GI exam was grossly normal. So with her concerns with the severe headaches that suddenly started, we got the CT head, which did show some type of subarachnoid hemorrhage here. See some hyperdense areas. And with the interest of kind of detecting where this is from, we did get a CTA. But quite frankly, the CTA wasn't too impressive for anything. So the next step was to kind of get a DSA to locate exactly where possibly it could be coming from. And this DSA is actually from the right internal carotid artery shot. And we see, for example, here we see the middle cerebral artery and then just the anterior cerebral artery. And over here, actually, we do see some type of saccular aneurysm that does show. This is another view of the same shot, but it seems like there is some type of aneurysm here that's going to be the ACOM that's inferiorly projecting. And the size was about 2 millimeters, and the maximum diameter was 3.8 millimeters. So it was a relatively small aneurysm that actually did rupture that led to the subarachnoid hemorrhage for this patient. So just kind of going back, I guess I am talking about ACOM aneurysms here, but I wanted to talk more on just aneurysms in general. And they're usually just dilations that occur at weak points along the arterial circulation within the brain. And I do want to kind of point out the fact that today I want to kind of mention on the saccular aneurysms, there are different types like mycotic, pediatric, and traumatic aneurysms, but due to the issues with time and complexities, I want to talk about only the saccular today. But these occur about 1 to 5% of the population, and there has been a little bit studies that shows that it's twice as common in women versus men. The diagram here on the right, you could see where it usually kind of affects. We see about 35% of the aneurysms are about in the ACOM area and about 20% in the MCA bifurcations, although these numbers are not 100% concrete in place. Every studies kind of have a relatively different numbers, but this is just a general guideline. Risk factors for the formation of aneurysms are kind of wide in terms of it can be things like genetic disposition, local hemodynamic stress, or things like endothelial dysfunction from medical conditions like hypertension or even smoking history. And symptoms are mostly kind of ranging all the way from asymptomatic to just mass effect. So it seems like actually a lot of these aneurysms are found incidentally, but for patients who do have some types of symptoms, mass effect is one of the things that they find. For example, it's very location dependent. So if it's, for example, in the PCOM, then you would have some type of cranial neuropathy. You could have things like vision loss if it's like in the if it's near like cranial nerve 2, and we could have just other symptoms in general like seizures and headaches. Actually, one fun thing I actually found just in general regarding these aneurysms is that there is some seasonal impact of these aneurysm rupture, and there has been studies showing that during spring and winter, there's actually a higher risk for aneurysm rupture, and they think this is because it's due to the drop in temperature and then the favorable climate because it's cold that allows for an increased blood pressure for kind of heat retention and whatnot, which I find it very interesting. But other than that, diagnosis, DSA is the golden standard. And CT and MRI has very kind of wide range of sensitivity. And this is mainly because of the fact that for smaller aneurysms, like for example, 2 millimeter CT is very non-sensitive in terms of 53%, but we see this does go up with a higher kind of size aneurysm, like 7 millimeters. Treatment for the aneurysm itself, not I don't want to talk about like the subarachnoid hemorrhage dealing plus the aneurysms, but just for the aneurysm itself. Before it ruptures, you could do things like conservative monitoring with repeat imaging, or for things that have ruptured, their options would be like surgery, which could be including coiling versus clipping. So the reason I chose this topic actually was because from what I've been taught originally, I thought the risk factors for aneurysm ruptures are pretty straightforward, and it was like a one study that just kind of clearly showed this. But the more I looked into I realized it's very heterogeneous. So for age and sex, it seems like a lot of these studies actually do agree that these aren't necessarily associated with these aneurysm rupture risk. So the formation I mentioned earlier, there is some type of sex component to it, but it seems like for these ruptures, all of this, they weren't able to find it. The study I'm actually going off of this is a meta-analysis that they've done regarding these risk factors for the rupture. And it seems like even among this analysis, it seems like for the age part, at least you could see the confidence interval is varying. And for the sex portion also, you have a kind of varying confidence interval. But for smoking and hypertension, this in the meta-analysis, at least by just strictly going off, we do see that it's 0.99. So we would say it's not statistically significant. But when we do look at subgroup analyses where we see just like Western countries or things where we just look at retrospective cohort, we do see smoking as actually a risk factor for these aneurysm ruptures. And similar with hypertension, we don't see it directly in a whole meta-analysis, but for prospective cohort studies, they did see that hypertension are a pretty high risk factor. History of subarachnoid hemorrhage actually also differs depending on circumstances. It has been also kind of a widely kind of agreed fact that history of subarachnoid hemorrhage does increase the percentage of rupture. And a lot of these actually kind of models that they created for unruptured intracranial aneurysms put this in their model to see if the patient has had a history of subarachnoid hemorrhage. But the meta-analysis does show that it's not necessarily always a go-to, except when we do see a subgroup analysis, we do see in Eastern countries or in prospective cohort studies, we do see that history of subarachnoid hemorrhage within the patient does kind of have an increased risk for aneurysm ruptures. And multiple aneurysms, and then the aneurysm factors such as like quote unquote large aneurysms, which every studies kind of do it separately, but the widely accepted notation is 7 millimeters, and the locations of these aneurysms like the ACA, MCA, and then vertebral basilar artery has been mostly kind of agreeing that these are actually kind of prominent risk factors. So I guess the big takeaway that I got from this is the fact that a lot of these things are heterogeneous. And even though we do kind of take it to the fact that smoking and hypertension, history of subarachnoid hemorrhage are kind of known, it's not necessarily always seen in all different types of subgroups. So I want to talk about a little bit more the treatment of the ruptured intracranial aneurysms, and this would just mean the aneurysms itself, not dealing with like the subarachnoid hemorrhage. And I mentioned earlier that the main go-to is going to be clipping and coiling. And there are actually 4 RCTs that have been published that kind of test this notion of coiling versus clipping. Before it seemed so just going for the first one, I guess. The International Subarachnoid Hemorrhage Aneurysm Trial, it seems like this was a study that was kind of like a landmark study done from 1997 to 2002. And they got around 2,000 patients to kind of analyze this. And it seems like overall, this entire paper, they actually published 3 where they have 1-year, 5-year, and 10-year follow-up. But the entire paper kind of connotated towards the fact that endovascular management are actually kind of positive in the ways of like quality adjusted life years and things like mortality, if you see the graph on the right. But they do also point out the fact that usually if you do coil, there are concerns of rebleeding, and just concerns regarding like complete occlusion. But it seems like overall this paper was leaning towards the fact that endovascular treatments are kind of on the positive side. There's another study that was kind of a little bit smaller by Lee, and this is also quote unquote called the Chinese study, but this has around 192 patients that they were now analyzed for subarachnoid hemorrhage. And overall, what they did find is that the complete occlusion was lower in the coiling group, but it seems like the clipping increases the risk of symptomatic vasospasm, which induce cerebral infarcts, which kind of reflects similarly to the previous study that talks about kind of the fact that in a short term, not a short term, but in a clipping, we do see things concerning with more mortality, but in the vascular group, we're concerned more of things like rebleeding or incomplete occlusion. Just going to talk about these two for the interest of time, but this study, I guess, when I first read this, thought this was probably a go-to kind of start off where like this is it, and the vascular is like the way to go. But there are a lot of pitfalls for the studies also that kind of needs to be considered. For example, the population for that trial was not necessarily representative of all subarachnoid hemorrhage patients. Within the trial earlier, about 97% of the aneurysms were actually in the anterior circulation. And that doesn't really necessarily reflect the general population who do have subarachnoid hemorrhage from aneurysms. And also, they found out that this quote unquote poor outcomes, which they did measure by the Rankin scale, the statistical significance kind of disappears when pulled anything differently. So what that means is for that paper example, they kind of pointed out the fact that poor outcomes are ranging from any scales from 0 to 2. Sorry, good outcomes are from 0 to 2 and poor from 3 to 6. But it seems like the moment you start kind of changing these numbers, if you go from like maybe 0 to 1 to like 3 to 6, 2 to 6, the statistical significance does disappear. And the biggest thing was also the fact that the surgical outcomes were kind of criticized as being unfavorable compared because despite the patient selection and the fact that there's a lot of aneurysms that are small, it seemed like there were not that many good surgical outcomes compared to what it would normally be. So people are actually questioning the neurosurgical expertise within the group who did do things like clipping, and also kind of point out the fact that there weren't really kind of numbers of ears that were pointed out there. And another study also kind of points this out where they did a literature review and they found about 47 studies that kind of question the same thing. And the verdict is very divided, where they say about 18 are going to be equivalent, and then they don't necessarily favor neither, but we have 18 that favor coiling and 10 that favor clipping. If you do add these up, it's 46, and that's because one of the papers actually just did not kind of comment on what they do think at the end. But the overall arching theme, I guess, that I got from this is the fact that it's the decision making for treatment of ruptured intracranial aneurysms is not as simple as, for example, just looking at whether the neck is very wide or anything like, where the location is. All of those things do have a factor. It seems like the decision is more complex, and there's no one study that actually points out the fact that one method is superior than the other, despite the fact that there has been a lot of advancements in endovascular coiling also. And just to finish this off, because we did talk about ACOMs in the beginning, I want to talk about maybe a question that was mentioned regarding management of unruptured intracranial aneurysms. And the reason I mentioned this is because traditional studies have really implied that small unruptured ACOM aneurysms have really negligible risk of rupture, and usually treatment was not warranted. In the International Study of Unruptured Intracranial Aneurysm Investigators in 2003, for example, they said the 5-year cumulative rupture rates for ACOM aneurysms that were under 7 millimeters are almost 0%. And this is a pretty good kind of go-to saying that, like, okay, we shouldn't treat this. However, it seems like there has been obviously some ruptured aneurysms, and they are actually the most common size of small ruptured intracranial aneurysms. So this study that I am kind of talking about right now kind of evaluated about 150 patients with very small ACOM aneurysms, not very small, but small ACOM aneurysms that were evaluated after intervention. So what they wanted to question was whether treating patients with small aneurysms, with small ACOM aneurysms would kind of be beneficial given the fact that this is 2018 and there has been increased technology and there's advancements in endovascular surgeries and things like that. to allow the mortality rate for surgeries to be lower. And it seems like among those patients, 12 patients had a poor outcome, but the risk factors for these were actually with the age and the fact that they had a previous history of MI. So the patient, I guess the paper decided to kind of question the idea, should we be a little bit more aggressive on the strategy of treating ACOM aneurysms if the patient is under 65 and they don't have a past medical history of MI? Because it seems like at least on the kind of graph on the right, we do see the two main things that kind of led to or is statistically significant with people with poor outcomes were these two. And again, the size between the good outcomes and the poor outcomes, they were not like statistically significant. So that was not like a factor that actually had an impact on whether patients did have a poor outcome. So I guess I didn't want to kind of end off with that general question, but other than that, that's all for my presentation. These are my references, and I just want to say thank you so much for the time so far here. It's been a great 3 weeks, and I'm very looking forward for the next week. And thank you, Dr. Shigematsu, for kind of going over this presentation with me too.
Great, thank you. It's a very, very good review, and actually it helps. It will help me. Actually, it re-educated me actually to make a decision and the follow up or the clinical decision for the rupture aneurysm in the clinic. Actually, that first part helped. And about the thank you for the review of the ISAC on all the RCTs, and thank you for giving it was a very good your opinion and your take up from these studies. I think that's true. It's not a one study showing, or it's not just the data we are making the decision based on. That is true, but it is good to have a one big strategy for per institution. I think we are.
I think we lost Tomo all of a sudden. All right, well, it was a very nice presentation. Thank you, Minjun. I think you were very comprehensive. Does anyone else have any other questions or comments before we adjourn? All right, thanks everyone. We'll resume next week. See you on Wednesday.